Hey, good evening, everyone. Can somebody confirm you can see my slides and hear me well and hear see me as well? You can confirm in the chat or unmute yourself and speak up. If you can hear me well, I'm audible and visible. Yeah, perfect. And you can see my slides. Right. So I think we've crossed 50 people. And it's 9:31. I'll give one more minute. Few looks like few more people joining, and then we'll start. Okay, you muted that. Yes. Okay, got it. So if you wish to ask any questions, then you please start putting them on the chat box. Okay, I'll give one more minute and we'll start. You all are pretty excited to come and see you all there. This is my first visit to Mauritius, so certainly look forward to meet you all and interact with you all and visit the beautiful country, which I will always been seeing lots of photos. Right, it's 32, so let's start. Okay, so good evening, everyone. So today I've been asked, I mean, there has been a good series so far. We have covered some part of the point of care in PPHN. I'll be just touch base upon few things today. So I've been asked to talk on topic of POCUS and its utility in a baby who suddenly deteriorates, something like a crashing newborn. Now, this is a very vast topic and we do a whole workshop for the whole day. So, but I'll try to give you some snippets about the POCUS use in newborn in the specifically in the NICU in next 40-50 minutes. So feel free to ask questions in the chat box. I'll just quickly go through my humble beginning and journey so far. I'm from Mumbai. I'm Indian and trained in Mumbai for my undergraduates and postgraduates in multiple hospitals, and then I could move to Perth, where I worked in Princess Margaret and King Edward's Hospital in Perth, where we had a 120-bedded NICU. I also was fortunate to work in a surgical unit in Royal Children's Melbourne, and then after finishing my FRICP Australian training. I went to Sick Kids Toronto and Mount Sinai in Toronto, where I could train myself in the TNECO program with Dr. Patrick McNamara and Luke Martins. And also pursuing my research interest, I did a research training at Harvard. And then with that experience, I could fetch a job in Christchurch, New Zealand pretty early on. I was there for a few years before I planning to move to India where but I did a stopover in Qatar, where I was working in Sindra Medicine, which was a very new, beautifully built, state-of-the-art mother and newborn center, mother and child hospital. And I was also fortunate to get my training of POCUS in Australia and in Canada. Sorry, just what is this bell ringing continuously? Okay, right. I think the bell stopped. I mute somebody. Okay, perfect. So, yeah, so I could do my training in ASM, something called as a proper program called as something called as CCPU, and also, oh, right. Sorry, this bell is distracting me for some reason. Mm, anyone has an idea where this bell is coming from? All right. Okay. So, yeah. So basically, after training in Australia and Canada, we started some training program while I was in New Zealand, and then in Middle East also we established the first ever program for echo and point of care ultrasound called as QNISH, which was in terms in line with neurologists perform echocardiography in UK. And then we sort of started a program at Wadia hospitals in Mumbai called as Focus In, and then sort of merged this focus program with NEFCO Academy with one of my good friend and colleague, Dr. Mohit, under NEFCO Academy. I was also fortunate to undergo a lot of transport experience in Australia, in Melbourne, in Canada, and I was also director for a newborn transport in Christchurch, South Island, and where we did a lot of telemedicine and even focus on transport. So the idea of sharing this is like it's just to show that I could actually get a lot of experience in most of the best of the centers across the globe. But when I came back to India, actually, I faced a lot of struggle, and actually that made me more wiser. That like you may not have always the best settings or best resources to save the life, but you have to train yourself in a better way so that you can save these lives with most of your knowledge and ability, and make use of the available resources in the best possible way. So there were few ambulances which I could see they were available in India, but unfortunately, despite like so much progress in care, in neonatal care and everywhere, still like cities like Mumbai also are dependent on transports like rickshaws and taxis, and you can see this is so called a cardiac ambulance where you can't hardly see a baby. And this is a 26 weeker which was actually backed by a father. And uh, and it was bought by a doctor, but he was not actually there looking after. And baby luckily came safely. I mean, he survived the transport, and we could manage and revive this baby. But I had to work a lot when I came back to India to improve the transport systems, and improve the situations and apply the best of the knowledge. And when I sort of moved from Wadia Hospital, which is more of a trust hospital, to the current hospital, which is MRR Children's Hospital, where I'm currently working and heading the unit, which is built in collaboration with Sick Kids. We first focus on the transport, and we sort of design an ambulance right from scratch, where everything is available as we could experience in the Western world. So I think this kind of uh, this is I felt like the way to give back to the society. You bring the best possible sort of equipments, and make use of the resources, and make something out of it best suitable for your situation. And which was the most well equipped ambulance with a defibrillator, transport incubator, and the T1 ventilator, which is supposed to be the best defibrillator, and the multi-para monitor. Apart from that, all the other essentials which are required, and we are able to telemonitor this as well remotely. But coming to the topic, so this is what happens. Okay, so just on a funny note, basically this happens in a ICU setting as well. Things goes uncontrolled, and you have to anticipate early that something is going to crash, a baby is going to crash. So sorry for the little distorted slide, but basically a baby actually in an NICU before crashing or before we could manage goes from this phase of stable phase to a death. So there is a whole journey from stable period to death, where a baby gives a lot of time actually for us to support the baby. And many times it is just that we are not able to pick up things, and then the babies basically crash, and then they go to a point where they are not recoverable. So there is always this there is always this auto regulation phase which is there in the initial phase. So you can basically have early clinical deterioration which needs to be picked up based on the vitals, and the use of trend monitoring with multi-para. But lot of time we don't know about worsening of the oxygen delivery, because we just go by the saturation monitors which are telling us the sats, but which many babies need to start dipping, and we just go up on oxygen to maintain that. But we don't know what is happening at the tissue level, what is the tissue oxygen saturations in the brain especially, and in the vital organs, that we don't know. And whenever the baby is in the disease state, there is a increased tissue level oxygen extraction which is happening because of the sepsis or any disease state. So the balance of oxygen delivery and supply is disturbed, and the baby goes into shock. And that's why, nowadays newer monitors are coming, like NIRS, near infrared spectroscopy, which actually can tell you about regional oxygen saturation in the brain and how much is oxygen extraction. And as the tissue oxygenation is falling, then baby goes into anaerobic metabolism. Then the your pH will drop, your base excess will get worsen, you will have a lactic acidosis which is worsening, and then baby will have a decreased oxygen consumption, and then the tissue oxygenation will drop further, and then baby will go into a very decompensated phase, and then you get multi-organ dysfunction, and that leads to death. So this is generally the progression of any baby who gets sick or goes into shock for various reasons, like sepsis or any other things. So I have a whole different talk. Maybe when we get a time in Mauritius, I'll talk about the what are the other modalities which will help you in picking all these babies. Something like a hero monitor, which is trend monitoring. There are non-invasive cardiac output monitors which are available, which tells you about the continuously about the cardiac output. You have the NIRS monitor, which will tell you about the tissue oxygen saturations, and then you have an echo or a POCUS machine which tells you about a lot of other things which are going on. So today's focus is, mainly we will talking about the POCUS use of the ultrasound machine, which is an important tool. It's a visual stethoscope now, it's a fifth or sixth sign now, which we talk about apart from the heart rate and, like looking at the vitals and auscultating. Now we tend to put up a now we tend to put up a probe to pick up the abnormalities using the point of care ultrasound. So point of care means that it is readily available bedside, and you're trained enough to quickly do an assessment and sort of gather the information why the baby or a child has deteriorated. And as you can see, this examination now previously used to be restricted to pediatric cardiologists for diagnosis and research purpose, but now many neonatologists and pediatricians are using it for a lot of functional assessment, PDA, PPH, and shock assessment, etc. Even in emergency ICUs, you would see that point of ultrasound care is very much used, especially for hemodynamic assessment, fluid responsiveness, etc. And even anesthetists are using it in the ICU and in the theater while the surgeries are going on and seeing intraoperative hemodynamic decompensations. So now I think the time has come, and especially last 10, 12 years, focus has actually penetrated in many, many fields, and especially in neurology, it has progressed very fast. And then every sort of but you know what I mean it takes time for the people to get trained. It takes at least 6 months, 1 year for a one person to get really mastered in focus, because it's very observer based modality, and if you're not trained, and your eyes always will see what your mind knows. So if you're not well trained, then many times you might miss things or you might overinterpret things. So to make it easier, there are a lot of these focused point of care protocols have been developed, where it's easy to train the doctors and nurses or the emergency physicians to make some focused assessment, so that you can pick up the major abnormal things, and then you can leave the detail like echo or detail ultrasound for the either the cardiologist or the radiologist. So you can see there is fear protocol, bleep protocol, race protocol, fate, fast, all these names are there, as you can see, specifically for in done by emergency physicians or the cardiac echo or trauma assessment, which are which actually specifically look at the areas of interest. So similarly, there is something called as a crashing newborn protocol, which is built to using the existing ultrasound protocol. There are protocols like safer in UK. Again, it is just devised by the neonatologist or the people experts in POCUS, to come up with some acronyms so that people remember how easily or quickly you can assess a life threatening event. So safer used to stand for sonographic assessment of the life threatening events. So I'll quickly go through this crashing newborn protocol, which will give you a flavor of the point of care ultrasound POCUS, which is a very useful bedside tool used by the clinician to assess the patient in real time. And not only that, it help you to monitor the disease progression. And also, if you have started the inotropes or given the boluses, you can evaluate the treatment responses. So it's done. The generally my unit, we don't move the machine. I have, once a sick baby comes, my machine is always bedside. I'll do a quick initial assessment, I'll do something, and again after half an hour, 1 hour, I'll do another assessment, and then maybe in few hours I'll make an assessment before I sign off from the place. So it's very very kind of useful tool. And many times I forget to auscultate it, but I'll never forget to do an bedside ultrasound. So, but it's not a replacement for a comprehensive imaging like the radiologist or cardiologist they do. But these are the focus protocols which we are talking about. And so, it's developed, as I said, for the specifically babies who crash in an emergency situation, where even pediatricians can do this, or even nurse practitioners can do this, and it allows quicker diagnosis and intervention. So this is the crashing newborn protocol, and I'll cover some of the aspects of the POCUS using this protocol. So as you can see, it covers cranial POCUS, mainly to look at the intracranial bleed, because those are the baby who deteriorate suddenly. Lung POCUS, looking for effusions or pneumothoraces, etc. Cardiac focus, which has got more role, looking for function, pulmonary hypertension, PD, or cardiac tamponade, or fluid response rate, etc. And abdominal focus for gut ischemia, free fluid. So this is the crux of my today's talk. Uh, we are 15 minutes in, and I'll take another 30 minutes to cover the different aspects of the focus. So, so far, I think this bell indicates that someone has signed into the Zoom meeting. Oh, right. Okay, thank you. So then let me see if I can. Uh, Now it will not play. Play and join leave sounds was there. Perfect. Thanks you. Thank you for pointing that. Uh, Sorry, this happens. I'm on call and I get a call from the NICU about a sick baby. Sorry, I had to take that call. Now the bell will not ring. Perfect. So, yeah, so this is what we're going to cover in today's talk. Okay. So, let's start with the cardiac focus. We'll start with a case. This was a baby who was referred from a government tertiary hospital, who crashed on day 2. Initially, he was born in a term baby, some meconium stem like a section, did not cry, very mild birth asphyxia. They are a good size baby. Apgars were 4 and 7, and required IPPV, and then kept the baby on CPAP. Now, by next day, the baby worsened. They did not have high frequency in government setup, so they put the baby on conventional ventilation with so-called maximum settings around 20 22 on 5. You could go up, but I mean that's what they transferred at the time. 100% oxygen, and the sats were not going up beyond 50 to 60%. And pH is 6.9, 38 PO2 only, lactate 16, basics is -20, and echo was not available, so they were not sure. And query meconium aspiration, black lung, they were thinking obviously could be pph or could be this thing. But any thoughts initially what could have gone wrong here? And they already started the baby on norepinephrine, adrenaline, sildenafil infusion with no benefit. So any quick, people can put in a chat box what is the impression here on this case. Pphn, anyone suspecting cardiac possible? Any particular cardiac disease? Pneumothorax, yeah, certain iteration can be pneumothorax, but then lactate and base excess may not be that worsen in pneumothorax and the pH. HIE, okay, so yeah, you're right, Apgars were poor, so HIE leading to cardiac dysfunction, also a possibility. So again, those are the things we want to know, right? And you want to know the neurological status, and that tells you what could have been the asphyxia to the heart and the other organs. So when we went, we saw the baby. Though always it was difficult to decide to take a transfer or not, because as I was talking, and that's the reason I covered the transport. That it's not that babies always come safely. We have to go and retrieve them. That's the first thing I started, we don't depend on any third party because the babies can crash during the transport. So we went there, and you can see the saturations were 47% only, and the baby was really, oops, sorry, it's not playing. Baby was really struggling, desaturating. We could stabilize this baby for some time and got the saturations up to 53%. As you can see, we have a good equipment to transport, and important is to hold your nerves. And I only advise to the associate was you keep looking at the heart rate, which is if it's not dropping, then I'm happy to transfer the baby because this baby is not going into the bradycardia, which is good thing, and I'll talk about it quickly. And you can see briefly we could get a stability to 98 degrees, 98%, and then the baby came with so much inotrope 765 transfusions, and then you could see that within the next hour or so we could stabilize this baby. This is our setup, and you can see we always have this pre-ductal post-ductal saturations. This was the x-ray, and not really bad meconium aspiration. So the lung fields are also well maintained, so it was the impression was that maybe it's just PPHN. So we put the baby in 20 on 5, and an urgent echo was performed. And I think we had already covered this. Dr. Shilpi has nicely covered this. That in a point of care ultrasound, for the echo, we do a lot of detailed assessment for PPHN. But when you do a focused focus for PPHN suspicion, then you just look at the TR, the tricuspid regurgitation. This is four chamber atria and two atria and two ventricles. So you see the blue jet which is going up, and that will tell you there is a TR. And also, as you can see, the septum is flattened, so it's like a D-shaped ventricle, and that tells me that okay, the pressures on the right side is very high and it's pushing the septum towards the left side. So I'm dealing with a PPHN, and then we do a continuous wave Doppler, what we called, which gives you the velocity, which is P max, and we have a formula which we can calculate it based on the Bernoulli's equation. That gives you a right ventricular systolic pressure. So as you can see, this is almost 3.5. So we are dealing with somewhere around 45, 50, 55 pressures. I mean, this is a little underestimated. We subsequently got about 50, 55 pressures. And what we recruited the baby, and you can see this baby was started on nitric oxide. This is a nitric oxide machine, and then we got a quick response, and because of that there is no pre-post ductal difference. We could stabilize this baby. This is the echo machine. As you can say, always we keep it bedside to assess, and even the blood pressure improved very nicely. But only thing issue was the tachycardia, and that was owing to the so much inotropes baby was already on, so we had to only back off, so the anatropes, and we could stabilize this baby actually subsequently had a with this thing, I mean pH had worsened. Actually, when we had a better function, we could get the TR even up to 80, so 20 ppms. And baby had another episode where baby actually went into crisis. So this is pulmonary hypertensive crisis. Typically what we see, that babies go into something like a fetal circulation, and again I will not spend a lot of time here, but basically they go into exactly the fetal physiology where they have right to left shunt. And this baby also had echo, had almost right to left shunt, little bit of reversal in the aorta, and the TR was coming up high. And then, but despite the saturation being around 50-55%, the heart rate remains stable because these babies actually don't feel that hypoxia. They are just in that fetal circulation, and they maintain that level for few hours. So you just have to hold your nerves, stabilize. And after the second crisis episode, we had to with the so much high pressures, and these pressures shot up. They were initially 50-60, but when baby went into the crisis they went up to 80. So we had to increase the pressures, kept the FiO to 100%, and continue the nitric oxide, and then we could stabilize this baby. So basically there was a Klebsiella multi-resistant drug, a bug which was actually making this baby flip into severe PPHN. But we could successfully discharge this baby with a normal MRI brain with no evidence of hypoxia. And that's important that, despite like for a few hours, baby was almost in 50-60% saturation, the brain was getting enough oxygenation because of the fetal circulation. Now another baby, use of sort of POCUS. Day 3 baby, 26 weeker, 830 grams. deteriorated, ventilated in 65% oxygen, and then increased pressure settings, and there was a metabolic acidosis, and echo was suggestive of this. So any of you want to comment on this echo or the this thing? This is the fixed focused focus for PDA. So any impressions on this? Anyone who are still trained for echo or are able to do it or interpret the echoes? What is the impression about this PDA? Sorry, the image is actually, the video is stopping for no reason. It should play continuously. Yeah. Anyone want to type in the chat box? Comment about this PDA. And the second question is, will you treat this PDA? So something has happened. A baby who was in honeymoon period for first 2 3 days, what we call, like first 48 hours they behave, and typically on day three this baby got worsen with more oxygen requirement and acidosis, and this is the echo. So what would you do? So right to left, Noorina is saying right to left. Crescent, crescent. Are you talking about the pattern, crescent pattern? And would you like to treat? Please write yes, Y if you want to treat, and N if you don't want to treat. So just type Y or N. How many of you want to treat? Please type Y. If you don't want to treat, type N. If I get at least 4 5 responses, I can move ahead quickly. So please type your response. We are here to just discuss. So no, Asil is saying no. N, anyone wants to treat? Yes, if PD is greater than 3.5 millimeters. Okay. Okay. Yes. Okay. Two more. Yes. Yes. Sandeep is saying yes. Okay. So looks like lots of yes. Anyone for no? One more no. Right. So basically, actually, the answer is no here. And as rightly, and I think we are not unmuting, but maybe I would like to hear from Asil. What was the reason you would like not to treat this duct? A lot of people say yes, actually, because it's a large duct. Somebody said 3.5 millimeters. So, uh, would you like to comment? I can just unmute you. I'm asking you to unmute if you want to just quickly speak up so that I
Hi.
get to. Ah, yes, Dr. Asil. Yes.
Yes. I believe it's a preterm baby, so it's normal to have a patent ductus arteriosus there. And if the baby has some pulmonary hypertension, this will help in offloading the right ventricle, most
Absolutely.
probably. Yeah.
Thank you very much, sir. Thank you very much to say that, sir. And that's the take home I want to give, that from this, so even if you don't know full echo, if you are able to see visualize the ductus and able to Doppler it, if you see this pattern where you have a you see here it's right to left, your it's blue red, it's blue and red jet, so it's both bidirectional. So red blue red blue red blue, so the blood is flowing on both the directions, and when you do Doppler, it is this is the right to left component, and this is the left to right component. So in one cycle you have a bidirectional shunt, and almost 40 50% is right to left. So as rightly pointed, this baby has a pulmonary hypertension because these premature babies take longer time for the pulmonary vascular resistance to drop. So this baby has something happened, and then there's a worsening of the pulmonary hypertension. That's why there was increased oxygen requirement. And if you treat this duct, it will make things worse because this premature myocardium requires this pop off to support the right ventricle against the such a high afterload, which is a high pulmonary pressure. So this is a duct which you don't never treat, and you should just watch. Even if it's large, if it is bidirectional, you need to just hold your nerves and treat the pulmonary hypertension. So you ventilate the baby, optimize the ventilation, sedate the baby, correct fluid status and all those things. Now, the same baby now, after 2 days, you've done the right things. The FiO2 has come down to around 30 to 35%, and the pressures are still about moderate. Acidosis is still persisting now. There's a more metabolic acidosis, and this is the echo. Now, will you treat these doctors now? So please write SY for yes for if you want to treat, and N for if you don't want to treat. Yes, anyone don't want to treat? Yes, Y, only one Y. Can I get some few Ys and few N's if anybody is saying? Okay, Mr. Asil wants to treat this time. Yes. Okay. So, Mr. Dhupul or Sandeep, one of you wants to speak up and tell me what is your impression, why you want to treat these doctors now. I will unmute you, Mr. Dhupul's iPhone. I've asked to unmute if you want to speak up. Feel free to speak up because it is good to be interactive. Okay, no worries. Anyone else want to speak up? Please raise your hand. Okay, no worries. So basically, yes, you are right. Most of you have said yes to treat, and I agree that this will I will treat. So what has changed here is this is red jet, it's completely left to right, a large duct, and we look at something pattern which is a pulsatile pattern we call it. It's an unrestricted pattern, just pulsatile. There's no this is a mirror image, so it's only the flow is above. So it's a left to right duct now. Now, I have not talked about the hemodynamic significant other parameters like LAO ratio and LV diameters, LLBO, etc. But even just by looking at these structures and looking at the situation where is there still little bit of oxygen requirement and metabolic acidosis, and this baby also developed little bit of hypertension now. So I would treat these doctors. Okay, so hemodynamically significant doctors. So just how quick assessment helps. Now this is the term baby was on ventilator. There was a PICC line in the heart and suddenly crashed. Okay, and this is the POCUS actually. Again, I've written the diagnosis, but can somebody comment? What are you? So this is something cannot be missed. Okay, and you don't need to have a really expert echo person uh, to like diagnose this. So anyone wants to comment about the management, what needs to be done here, and wow, what is your observation here? I've written already it's a pericardial effusion, but is it a mild or a moderate or a severe? And what are your comments? Please type in the chat box. So if you take a cardiac focus, a cardiac probe and put it on the heart, this situation anyone can actually diagnose this. You don't need to, even if you don't understand this is heart is upside down or inverted or a normal upside down, you will know that there is something wrong here. Okay, so it's a massive pericardial effusion. You can see that this wall is quite compressed. Severe, yes. So might need pericardiocentesis. Severe, yes. Large collection of fluid around the heart. So you can see like you would not miss this, and nobody should miss this because if you miss this, and you will this baby will not last very long unless you did a temporad. And we have a like a video image of draining this heart and subsequent echo images where the baby actually improved very quickly. Only sign that there was muffled heart sound. We couldn't hear the heart sound at all. And baby's blood pressure crashed, color changed. A very nice pink looking baby suddenly becomes cyanosed. So we thought there is a pneumothorax, and then I just put the probe on. This is the echo I saw, and then we called the cardiologist and read it. The baby survived. Similarly, you can see a 3-month-old who was fine at home and then came with some febrile illness and then presented with shocked mortal extremities. And any impressions here? Again, even if you don't know echoes, if you know how the normal heart looks like, what is the impression here? So this is the right ventricle, this is the left ventricle, and this is another view called as plaques view, uh, whereas short axis view. So it's a very dilated heart, very dilated left ventricle. both ventricles, but mainly it's a LV which is like significantly dilated. Again, and you can see, I mean, this image is not moving. We have a this thing, but even this heart, you can see that in the another view, same baby. Unfortunately, actually darkers. It's a very nice video, but somehow in the presentation it doesn't play. So here also both of the I would say the same. So basically, they are very much dilated, as you can see here, very dilated and abnormal movement. So very, you can see this compressed, pushed septum, and even here, when you do this functional assessment, you see there's hardly any movement. I mean, we got it worse, like 16% ejection fraction, 7% FS, very dilated heart. You can see like there's hardly any movement. So the heart which is hardly moving. So it's a crashing dilated cardiac myopathy. And again, you don't need, only thing you need to know that okay, this baby, call cardiologist, start some ionotropes, and don't give fluids. Even if you do these things, you will save the baby. And that's all. You just need to put the probe on and okay, there's something wrong with this grossly with this heart. Same the again this another baby, who came with viral illnesses and pale looking, and we put the probe. See again, hardly the this thing is moving. So myocarditis, it's not dilated and it's thickened, but a lot of inflammation, brightness, echo. So it's a myocarditis with poor function and poor ejection fraction. And then the last thing in the echo focus is fluid responsiveness. So you can look at the IVC diameter as a simple thing in a parasternal, in a subcostal view, in a 12 o'clock view, and we will probably talk it during the POCUS workshop in your respective hospitals, where this is the lever and this is the IVC which is coming and entering the right atrium, and you can just do a M mode along this, and you can see like the movement of the IVC expiration and inspiration. Now there are different IVC contractility index and all those things that we don't talk in POCUS. We just see that if you're able to visualize a good IVC which is moving with inspiration, you're able to see the waveforms changing in inspiration expiration. That means you're well filled. If you're not able to visualize the IVC, it's collapsed, then probably you're underfilled. And if you're very congested and there is no variation in the inspiration expiration, probably you are very fluid overloaded. Or you might be on a high frequency ventilator where you have a lot of back pressure changes and you IVC looks very congested, despite fact that you might be intravascularly fluid depleted. So that is again, that is a corollary and a limitation of the POCUS, that on a high frequency ventilation especially, we see the IVC looks always congested, and we still give sometimes boluses if you feel baby is hypertensive. So a baby whose IVC is collapsed will tend to respond to fluid, and you can always check with the in the four chamber view also. This is a little underfilled heart compared to this, which is a overfilled heart, a baby with PDA with volume overload. It's a overfilled heart. So you can do it in the just looking at the eyeballing the chambers also. So again, you don't give fluids in this heart, but you can give fluid in this heart. Okay, so this eye impression. So that brings to the end of the cardiac focus. We'll take questions at the end. We'll move on to the cranial focus. Now, cranial focus, generally there are a lot of indications of cranial focus, and we have a like again a whole 4 hours workshop for cranial focus, where we talk about what are the different views, coronal versus sagittal, and what are the dopplers you interpret and what are the abnormalities you do interpret. But in focus or the crashing newborn protocol, generally the reason for deterioration, a baby who's was fine in the evening, a preterm baby suppose, and then suddenly deteriorated and look pale, and there is hypotension. The general cause is IVH. Okay, so this is a 28-week baby, become pale and then shock, and you can see that this is a coronal section, this is a sagittal section, and you have to make sure you are very well central, so that then you see two uh, horns of the lateral ventricle, and normally you will see a very clear cut black margin like this, but you can see here there is a hyperechoic shadow, there is a increased echogenicity which is there, and that tells you there is a bleed there. Then you have to confirm this on the sagittal also. That is okay. The same blood I'm able to see the sagittal view also. This is left side. This is right side. So I will do a scan on the left side sagittal and see. Now this is a choroid plexus, which is normally there, but this is the whole thing is the blood. So this is the blood which is there, and it's filled up the ventricle. And as we all know, there are various grade 1, 2, 3, 4. I'm not worried about grade 1 and 2, and we are not bothered about picking up grade 1, 2 in the POCUS crashing newborn protocol. We're interested in grade 3 and grade 4. And then, as you can see, the same baby actually got worse as the baby was sick, coagulopathic. The whole ventricle almost is filled up with the blood. Some more blood has come up on this side, and it's gravitating to the posterior limbs as well. And as you can see here, there's a you cannot differentiate between the choroid plexus and the blood, because this whole blood is gravitated posteriorly. There's a big clot there, and this baby will eventually will have a ventriculomegaly and dilatation. Again, you can see some more focuses like that. So again, and we have faced this, like in the middle of the night, maybe got worse. Generally, radiologists getting in the night is always hard. They will say, "I'll come in the morning," and so you can do the focus. And if you see this grade 3 or grade 4, for grade 4, you'll have a parenchymal bleed here, like this. On the parenchyma, there will be a big bleed. So then you if it's bilateral and baby is very sick, then you don't need to stretch these babies and pump fluids or the blood products just to stabilize, because you can then talk about withdrawal of the care, or you can say tell the parents that, okay, this doesn't look good, maybe we should not push the baby, and all those decisions are important. Or if it's only grade 3 on one side, you might wish to continue, then you can quickly transfuse, stabilize the babies, and at least make sure that you have corrected the coagulopathy. So it's really useful. This could be the first sign of the baby getting worse, and so you can again save the baby from getting bleed from lungs or any other vital organs. So that's the cranial POCUS. Coming to the lung POCUS, so again, lung POCUS is something one of the easiest one to learn, and I think one can learn it in a 1 or 2 days. But to learn different pathologies and to train your eyes and brain, you need to see those pathology over the next 3 to 4 months. And again, we do conduct a separate lung ultrasound course as well, where we talk about a lot of pathologies apart from like from RDS, TTN, meconium aspiration, pneumonia, consolidation, collapse, BPD, diaphragmatic hernia, diaphragm movements, etc. But in focus or the crashing protocol, mainly the baby suddenly deteriorates because of the pneumothorax or pleural effusion. So again, lung ultrasound is one modality where we are not actually scanning the organ. You are actually uh, creating this artifact which are called as reverberating artifacts, which actually are created from pleura and the other subcutaneous tissues, and when the ultrasound waves are passed across the your intercostal space and the pleura into the lungs, so depending on if you have air versus air fluid interface, these artifacts will change. And if you do M-mode also, the appearance will change. So basically, lung ultrasound is nothing but a pattern recognition. And initially, you will see like it's a black and white, like in the old time, you will see this black and white TV which doesn't work. You will see all black, black, black dots, something like that. It appears, but basically, in simple nutshell, like this is your subcute tissue, and then you have a ribs which are this. So this is rib, this is rib, this is another rib, and then the rib obviously doesn't transmit the sound, so it appears black. So these two black shadows are there, and then the intercostal space will transmit the sounds waves, which is ultrasound waves, and you will create some image there. So normal ultrasound will see this batwing appearance where these two black things are there, and in between, like it's a body of a bat. Anyway, it's too short time to explain, but basically what happens is, again, we're not talking about lung focus fully here, which again when we meet there we can talk about it. But basically what happens, if this is a pleura, uh, the lung ultrasound will create reverberating artifacts like this, and what a horizontal line if there is a hole is lung. Then there's something called as a bamboo sign, where you will see the horizontal lines which are there. And if the fluid comes in between, like in TTN or RDS, then these lines will disappear, and you will get a vertical lines which are B lines. So there's something called as A lines and B lines, which depends on the severity of the fluid or consolidation. These patterns will change. And in a normal lung, if you put a M mode, you will see different shades of like subacute tissue or intercostal muscles, pleura, and then the lung will look like a sandy appearance. So it is called as sand on the beach appearance, because all these tissues will appear like a sea waves or on a seashore. So it's called as like a seashore or sand on the beach appearance, which is a normal lung. But so this is what I was talking about, the normal lung. Uh, so this is the again the rib. This is the pleura, which is very sharp. This is the subacute tissue and muscle and skin and all those things. As you can see, this is the pleura, which will create a equidistant horizontal lines like this, and those are the artifacts. Actually, they are the mirror or reverberating artifacts. So it is creating a artificial pleura image here, 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 and that tells me that there is a normal lung in between. And that's why if you put like this, it's a bamboo sign. So this is a normal lung. And other thing part of the normal lung is something called as about the lung sliding. So lung moves in the pleura. So basically the pleura, the two in the pleural space, the lung should move. So if the lung is moving nicely, I'm happy that okay, pleural space is existing and the lungs are moving nicely. So this lung movement also needs to be appreciated in a normal lung. But what happens is your this predominant A lines, as you can see here, these predominant A lines will uh, get, if the fluid comes in, you'll see these A lines are disappearing now, and some vertical lines are coming because this portion has got a vertical line. There are no A lines because the fluid has come in between. Somewhere there is a fluid there. Either it's TTN, transient tachypnea of newborn, or RDS, immature lung. And this get worse to have this pattern. As you can see here, no A lines, no horizontal lines. You are able to only see some rib shadows and almost like a whiteout lung. This is what X-ray you will see on a whiteout X-ray of an RDS. So the lung also you can see this. So again, maybe who is just born, you haven't done an X-ray. If you see this, I'm happy. If you see this, I'm not happy. So you can just quickly, so and there are lung ultrasound scores and all those things which we can talk about, decision about surfactant rate and all those things. But that's not really part of the lung POCUS, because those are the babies where who are born preterm, already their RDS and all those things. But lung POCUS is very useful in deciding about the severity of the RDS and decision to give surfactant. And also in MBOD, this is the I was talking about, the plural line lung artifact. So you will see this is a C, then there is a plural line, and then this is a beach, the lung, sand on beach appearance, the normal lung. So now what happens with the pneumothorax? So in pneumothorax, there are two classical things which will happen. So if a baby suddenly crashed and deteriorated, you awaiting X-rays, and you want to know, generally you will do a translumination, right? Like in your unit, probably, if you have. But generally, again, there are limitations of doing transillumination. So if you do lung ultrasound, uh, two things you talk about. One is about sliding. The second thing is about M mode. So if you see this one, see sand and sea, because it's a normal air is there and there is no air in between the pleura. If the air comes between the pleura, it actually distorts. You can see this reef shadowing and this parietal pleura, and there is a pneumothorax here now. So basically, you will get a that portion of the lungs will actually just have a horizontal lines and it will not reflect the lung shadows and pleural shadow. It will create multiple pleural shadow because there is excessive air now in between, and it creates something called as a stratosphere side or a barcode side. So I'll show you a barcode how it looks. So this is what the normal lung seashore side, and there is also the movement which is there. So what happens is, because in normal lung there is a movement in the parietal pleura, so you will see there will be a movement which is happening And when you put an M mode, is a motion lung which is seashore side, but here in pneumothorax, you will get something called as a barcode side. See, this is how the barcode looks, right? So barcode appearance will come, very classical for pneumothorax. And also there is a loss of lung sliding. So motion wall, there is no chest wall motion. So suppose you have a pneumothorax in this region, you will if you put barcode side, lung sliding will be absent in that region, and you put M mode, you will get a barcode side. So very classical loss of lung sliding, barcode side equals pneumothorax. In pleural effusion, again, if you are not able to hear sounds, you put a pleural effusion, you will find the pockets. So this is a in the basal region, there is liver right side, and you can see a pocket of fluid. Again, this also, because if the fluid comes in between the pleura, there will be the loss of lung sliding which will be there. And then if you do a proper focus at the base of the right side of the lung, or even on the left side for that matter, you might be able to see liver, and then this is the fluid space which is filled up with the fluid, and sometime your the lung is flapping, the tip of the lung is flapping in this free fluid called as jellyfish sign. And if you put an M mode, then this the margin of the lungs get actually like a sinusoid waveform in the fluid. So it's called a sinusoid sign on the M mode. So lung ultrasound has got lots of signs. I'll not cover this here, but basically, if you put a probe, you should be able to pick up a large pleural effusion and a large pneumothorax. So that's the lung profile. So again, I'll not go into the other sides. Central line focus. Again, this could be deceiving. X-rays could be deceiving. Many times you will see the lines going like this, but they are actually going in the other area. So you can always track the lines doing focus with focus if they are in liver, if they are in IVC, or which part of the hepatic vein. Abnormal UEC tips can be picked up if they're entering the liver part. All those things can be picked up, and you can see again a tip in the liver. So a lot of utility of for umbilical lines, and obviously you need to correct, otherwise a lot of these babies get into trouble. You can do an ultrasound guided umbilical line insertion also, if it's possible, you're trained for that. And again, this is UAC also. You can see where the tip is. If there is a clot around the UAC, all those things can be put up. This is in the aorta, in the coronal section, like this is a genital section. And you can actually put difficult IV access using POCUS. So this is again a quick sort of you can cover the probe, clean the area, get it ready, and you have to be very much aseptic. You cover the whole probe like this, and then put up the gel inside, and then that actually the focus can actually help you visualize the veins very nicely. And once you know the veins and where they're located, you can actually see here. You can actually direct the line easily with the focus. Okay, last, which I'll brush through because only 5 minutes left and we can take some questions. So abdominal focus. Now, this is something little gray area and not very easy to master. Even I, like me, we rely a lot on the radiologist, but certain things are easy to see, like bowel thickness, and if you have a large fluid or baseline effusion, and even peristalsis, you can sort of pick up. Intramural gas sometimes is hard to pick up, and so we need to know what is normal. So generally we put a color drop, and you will see at least 5 to 7, 8 speckles are there. That means the bowel is well perfused. You can look at the thickness of you can look at the lumen and echogenic linear markings of mucosa and hypoechoic muscularis. So this is what normal looks like. And suppose you have a thickness, will just see that wall is thickened very very. Look at this thickness here, from here to here. This whole thing is thickened. So if you see this kind of bowel loop and loss of differentiation, then there is a problem. So you're probably dealing with early neck. So loss of echogenic pattern, this kind of pattern, or bowel loops are distended and more echogenic walls, and sort of there's a bowel loop or stuck together. Then you know that you're dealing with the neck. And in subsequent stages, what happens when the bowel gets stretched and necros ischemic, then there is a thinning of the bowel. So less than 1 millimeter thickness will suggest that probably you're dealing with the neck already. So all those things, and then you can see there's a fluid around it as well. So all those things are very important to pick up. Now, this is very classical. If you see this appearance, that's very classical of a intramural gas. And this is thickened layer of a bowel wall. So you can see the very thickened layer. And you can see there's some intramural gas as well, which again, you may not appreciate from the beginning. You just need to train yourself and with your radiologist. And hyperechoic granular intramural gas is there. This is just a fluid collection and some more fluid collection. And then this is very actually very interesting that echo ultrasound was done and the baby actually perforated, and you can see the bubbling going inside in the fluid. So actually free intraperitoneal gas and leaking of the gas which is happening. You could see that in the real time of the POCUS. And this is again through POCUS with some fluid debris, etc., which can be picked up. So to summarize, crashing newborn in infant protocols, they're helpful to diagnose, the origin, where the origin of the organ which has caused sudden deterioration. What went wrong? Was there pneumothorax, pericardial effusion, or an IVH, or an abdominal pathology? So, it's easy to pinpoint where something went wrong, because all the newborns don't give size, all the size looks same, everything looks like sepsis, but we treat it like sepsis, but you might be missing something which is underlying, and that's where the focus comes in the picture. And there aren't enough cardiologists, radiologists in the world to meet needs of the neonatologists and pediatricians. And especially after hours, even I'm in Mumbai, which is one of the most advanced cities in India, we also find struggle to find cardiologists coming in many hospitals, and the radiologists especially coming in the after hours. So it's so that's why I think most of us, the neonatologists, have moved beyond PDA on POCUS. Previously we used to call be actually people used to annoy us by calling, oh, PDA doctor is here, because we used to keep looking and getting excited with PDAs, but that time has gone 12 15 years ago, and now we are doing more into POCUS apart from echo. And but important is that we need to still have a special bond between the cardiologist, radiologist, and neurologist, because if you find a structural abnormality or something very unusual, we still have to call our cardiology friend. Again, if you find something abnormal in the brain to a certain specific diagnosis, still need radiologist. Abdominal pathology is also, I was telling, like, even I still sometimes feel that I'm not confident that I have ruled out everything. So we do call radiologists for a formal ultrasound. But yes, detecting sudden things, function of the heart, PDA, PPHN, shock, cardiac tamponades and lines placements and head scan, pleural effusion, etc. It is very, very useful, and that's why more increasing number of pediatricians now are learning with POCUS, and it's a need of our hour. And earlier we train ourselves, it's better for the management of these babies. So with that, I will stop this thing. I think we just started a batch for echo and POCUS training with my colleague Dr. Mohit, and the next one we will start in January. So I'm happy to take questions if any. This is just 2 minutes before I finish. But as I said, I have know that it's a 50-55 minutes talk, and maybe 5-10 minutes lecture. So happy to take any questions and comments. So I'll just make it anyone can participant can unmute themselves. So anyone can unmute and speak up or give comments, ask questions. Happy to answer them. Naveen, are you there? Dr. Naveen? I hope it wasn't too much of information, but this is just a flavor of point of care ultrasound, and the details are a lot more details we go through when we actually see the cases.
It was just fantastic, Kiran.
Oh, thank you, Shilpi. You were
Yeah, I don't
there.
know where Naveed is, so I'll take this opportunity to say,
Okay, thank you.
I hope everybody enjoyed it as much as um, Kiran and I did. I'm sure there's a lot more for him to offer us when we get there. This was a little bit of a quick
Really.
giving you just the points, but there's so much more, especially for the cardiac ultrasound, that um, we will discuss more.
Any questions, comments before we sign off? One comment from anyone? All right.
I
No
think
comments.
the cases that you presented, looks like everybody enjoyed that a lot. And so maybe we should use that kind of a format when we come there, just using cases and
Yes,
having
yes.
an interactive session where people are, understanding and
All right. I think the comments are taking time to come. I think this is slow. Yeah, yeah. So thank you for nice comments. Very interesting. Great presentation. Hope we learn once you come over. Fantastic talk. Amazing. Can't wait for hands-on. Thank you. That was interesting. Thank you. Thank you for wonderful comments. Yes, we are also excited to meet you all there and interact. And as I said, this is my first trip. So looking forward to come there. Okay. So no questions. We can answer the questions once we meet there. Okay. Thank you, Shilpa.
we'll bring some case presentations here.
Yes, we will. We will.
Yeah,
We have lots
thank
of
you.
cases to discuss. Yeah,
Yeah,
perfect. Thank you very much. Good
thank you.
night.
Bye.
Good night. Bye
Thanks
bye.
again to Dr. More.
Thank you. Thank you.